Great. I'm so happy today to introduce Dr. Amy Wilkerson. It was through her love of medical anthropology that she eventually decided to pursue medicine. Before medical school, she worked in public health for the state of Oregon, focusing on preventive care. She then matriculated into a combined degree program in medicine and public health at OHSU. And upon completion of her family medicine residency in 2009, she began to work at Group Health here in Seattle, which is now Kaiser Permanente, Washington, as a full spectrum primary care physician. This eventually led to a focus on geriatrics, yay, a geriatrics fellowship, and now her role as a physician in post-acute care, long-term care, home-based palliative care, and hospice. I'm also very happy to introduce Dr. Cindy Burdick. A Seattle native, Dr. Burdick pursued medical training on the East Coast, graduating from Johns Hopkins University School of Medicine and serving as the chief resident at Harvard Internal Medicine Pediatrics. She is board certified in internal medicine and pediatrics and joined Group Health, came back here to Seattle, which is now Kaiser Permanente, Washington, as a primary care provider in 2011. And since 2018, Dr. Burdick has served as the KPWA Associate Medical Director of Medicare and Medicaid. Her areas of interest include development of population-based systems to achieve equitable, high-value care. And we're very fortunate to have both Drs. Wilkerson and Burdick come and talk to us today about clinical prevention in older adults.
Thank you so much, Dr. Cochran. We're both really happy to be here today, and it's a pleasure to speak to you about clinical prevention in older adults. It's also a treat for me to get to co-present with Dr. Burdick, so I'm so pleased to be venturing into this with her. So I'm glad you can see my slides okay, and it looks like they are forwarding as well. So we hope this is a really interesting and informative talk for all of you. We know that you're coming from different places geographically and that you may have different backgrounds representing a variety of disciplines, whether that's a nursing background or advanced practitioners, pharmacy, social work, physicians. We hope there's something in this talk for each of you. And if nothing else, hopefully it will satisfy your curiosity for this topic to some degree at least. These are our learning goals for the afternoon, and those include understanding a framework for prevention and being able to apply that to older adults, learning where to go for prevention recommendations for older adults, learning some key concepts about what makes prevention different in older adults and how to apply those concepts, and then also applying the two experts model of shared decision making. What this talk will not do is walk you through a list of preventive recommendations one by one for older adults. And we hope that's not what you were looking for. Instead, we want to show you where you can go for those, how to apply the concepts, and so you can utilize those in whatever work you may be doing, whether it's with direct patient care or whether it's forming guidelines for your institutions, whether it's writing note templates or doing annual wellness visits, or even just talking with your own family members or loved ones about what preventive care might look like for them. We have nothing to disclose. And I like to start all of my talks with you saw the 4 M's of age-friendly health systems, which was a perfect introduction. I always start my talks with the geriatrics high 5, which includes a 5th M of multi-complexity or multi-morbidity. I am not a super coordinated person, but I often am giving my patients high 5s. And so my kids had to teach me the way to actually give a high 5 and not miss is to aim for the elbow. So I put this on there in case that's also helpful for you. So let's get into prevention. The preventive measure that has been on our minds for nearly a year and a half, of course, is preventing COVID. Classically, prevention means keeping something from happening or from forming. We don't know yet what the pandemic is going to do in terms of how older adults will fare with their prevention and screening during the pandemic, and whether we're going to see, potentially worse outcomes as a result of delaying care. But that's something that is certainly being studied and we'll know more with time. One reason why we're not going to review just a list of recommendations one by one, besides being what we think is probably a slightly less interesting talk, is because prevention can mean many different things. And the complexity of prevention has really increased with time, as we've seen across a lot of clinical spectrums. The sheer numbers of recommendations have also increased, and they may continue to change with time. So instead, we're just going to, again, give you some tools and let you know that there are also multiple organizations that might be providing prevention recommendations. And sometimes these organizations can even conflict one another. They come from a variety of resources, as you can see on this slide. We wanted to highlight that prevention also doesn't just mean preventing disease onset, which is what we mean by primary prevention. It can also mean secondary prevention, which is preventing the progression of a disease, or it can mean tertiary prevention, which is reducing impairments or disabilities that are associated with a disease. And I will give you some examples of those. One of the most trusted resources to go to for prevention recommendations is the Uspstf, which I'm sure you are all very familiar with. And just a few words about the Uspstf are worth noting. It's an independent body of volunteer experts that serve a 4-year term, and they are carefully vetted for conflicts of interest. So you can feel reassured that the recommendations that they have are not due to having a secondary interest in remitting money for services that they're providing or other things. They systematically review the evidence for clinical preventive services, and they divide their recommendations into 3 areas that you see on the left of the screen. That includes screening tests, things that we classically think of like cancer screening or DEXAs. It also includes counseling services like falls prevention, weight loss, alcohol use, or skin cancer. And it also includes prevention medications such as aspirin, statins, vitamin D and calcium, and breast cancer medications for people who are at higher risk. I really like this poster from the National Cancer Institute that highlights a variety of primary, secondary, and tertiary prevention strategies all in one, very seamlessly. It's really accessible and it's understandable to the public. You don't have to know whether it's primary, secondary, or tertiary, but it just gives you a nice visual of what those prevention strategies might be, and also sort of highlights the vastness of potential prevention recommendations for people in kind of plain language. And then finally, just to show you what the broad landscape of prevention looks like, the American Geriatric Society White Paper on Healthy Aging lists 5 domains of prevention. And those include promoting health, preventing injury and managing chronic conditions, optimizing cognitive health, physical health, mental health, and then one that of course has been super important during the pandemic, facilitating social engagement, which we've seen a lot of depression and secondary effects of lack of social engagement with our older adult population. I won't read through this table, but this breaks down each of the 5 domains into primary, secondary, and tertiary prevention strategies, and then gives you examples of what those might look like. And this is the second half of the table that has the final 3 domains on it of optimizing physical and mental health and facilitating social engagement. So you can see a wide variety of examples of preventive service recommendations from the American Geriatric Society. The benefit of screening, of course, is classically, if you can diagnose something earlier in the course or prevent it, then that leads to improved outcomes. This pictograph illustrates that very well. It shows you the 5-year survival of those diagnosed with colon cancer at a stage 1, as opposed to at a stage 4, and shows you that the outcomes are better at earlier diagnosis. That is the classic goal and the benefit of screening and prevention. Unfortunately, while we tend to think that any prevention is good and that we should always go for preventive measures, it isn't necessarily the case. And this can be kind of a difficult shift to make while we think about what the potential harms are, physical harms or psychological harms of prevention and screening. You all may have examples from your own experiences where someone may have been harmed by prevention or screening measures. So I don't want to understress the potential harm. Overdiagnosis is one of the main ones that I want to highlight, which is the detection of an asymptomatic condition that ultimately would not have gone on to cause symptoms or death in someone. Other potential areas of harm include false positive results, hazards from the test itself, like biopsies or colonoscopies, for example, the adverse effects of unnecessary treatment, the cascade of testing that happens if you have a positive result, whether it's a true positive or a false positive, and finding incidental lomas or incidental findings that then warrant at least some attention about what you need to do after finding them. A labeling effect where someone may consider themselves either disease-free or of having the disease, and some of the psychological implications of those labels. And then also diverting resources from providers where you may find that your time is better spent on screening and prevention prevention that's actually recommended, as opposed to things that might not be recommended, but are finding yourselves talking with people about tests that truly are not recommended. So this brings us to thinking about what the critical elements of screening tests are. Any organization making recommendations should consider these and ideally have research to back up what they're recommending. And this is really just kind of public health 101, what constitutes a good screening test. Whatever you're screening for has to be a serious condition, and it needs to be prevalent in the population that you're looking at. The disease should have an asymptomatic phase that you can detect by screening. The screening has to be safe. It needs to be sensitive and specific, meaning not too many false negatives, not too many false positives. There has to be effective treatment available early in the disease course that's going to improve your outcomes. Costs have to be acceptable. It can't be wildly expensive. And then ideally, screening should have been found effective in randomized control trials. So in other words, recommendations have to offer a positive net health benefit when you take the benefits and subtract the harms from whatever test you're thinking of doing. This is where I want to introduce the concept of two experts to you, which is in shared decision making, and applies really especially to older adults when you're thinking about prevention. So you bring a professional expertise to the table that where you're understanding screening options, you have a sense of life expectancy, you know how long it takes to benefit for a screening test, and we're going to get into those concepts more later in the talk. You know what treatment options are, and you know what the outcome possibilities are for people. But the patient is the other expert in the room, and they bring their own expertise to the table about what matters most to them. One of the 4 M's or 5 M's. They might have their cognitive status is very important. If someone has dementia and can understand what the recommendations are or not, their functional status is important, their own experience of illness, their social circumstances, their attitude to risk, whether someone is more risk averse or not, and what their values and preferences are. That leads to shared decision making or mutual decision about a screening test, for example. So what makes prevention and screening different in older adults? This is kind of the money slide for you. We know that not every 75-year-old is created equally. There is significant heterogeneity within older adults when it comes to their medical problems, when it comes to how dependent or independent they may be for their care and their ADLs or IADLs. There may be heterogeneity in terms of numbers of medications. And because of the significant heterogeneity, that kind of changes the landscape of prevention and screening for older adults. And what that means is that there are a few other things that we need to consider when we're talking with older adults about prevention and screening. One of those is what their life expectancy is. I'm not sure if any of you have ever known a patient or a friend or family member who may have a terminal condition, but then gets a postcard in the mail for a screening mammogram, for instance. That is an example of where that postcard was not sent out with a consideration of life expectancy. You don't want to offer an intervention to someone that's not going to benefit them in the time they have remaining. You have to consider what matters most to people as you're talking with them about prevention and screening, and really all of their medical care in late life. And then also considering what their cognitive status is, as I've touched on some as well. With older adults, thinking about the frailer that an older adult is, the more risk there is in doing screening tests that have potential side effects. So for example, if you're thinking about putting them under anesthesia for a colonoscopy, there's a greater risk of delirium if someone has cognitive impairment or is frailer. And so just kind of putting that into perspective and thinking about frailer older adults in particular have more associated harms with screening tests. So this is why we can't just take a list of screening tests and give it to somebody and say, go accomplish all of these. I wanted to highlight the Choosing Wisely campaign for those of you in the talk. If you've seen this before, you'll know that the Choosing Wisely campaign covers a wide variety of different topics. And one of the topics that they cover is prevention. There are a number of different Choosing Wisely recommendations. There are at least 10 of them, but this is one that I just wanted to pull out and highlight. And this is from the American Geriatric Society. And this Choosing Wisely recommendation says, don't recommend screening for breast, colorectal, prostate, or lung cancer without considering life expectancy and the risks of testing, overdiagnosis, and overtreatment. It's a fun website to explore if you haven't seen the Choosing Wisely campaign, and it just has some really great information on there that can be supportive to you if you are talking with patients. So we're going to talk more about the things that make prevention and screening unique in older adults. But first, where do you even go to find prevention and screening recommendations? I'm just going to run through a number of places that you can access these recommendations, keeping in mind there may be some variation in how they're presented or what they're actually recommending for or against. Again, the USPSTF is kind of the preeminent place to go for information. This is a screenshot of the website that links you to the calculator that you can use to pull up recommendations for patients of varying ages. I circled at the bottom left, you click on the bottom left if you want to use the web-based resource or calculator for it. But there's also a really nice, easy to use app that then you can see a screenshot of that on the phones on the right-hand side of your screen that you can utilize in a mobile setting or a clinic setting. This is what the web-based service looks like, calculator. And you can see on the left of your screen that you put in the age of the patient and some other characteristics. It doesn't stop there. It actually scrolls down even a bit further, but not much. And then it'll pull up recommendations and give you the grade of the recommendation. So you've all seen an A, B, C, D, and I recommendations from the USPSTF. So it'll list those out for you. And then the amount of information here is quite rich. And I'll show you a little bit more of that later in the talk. This is what the report actually looks like after you have after you've plugged in the age, and you can then click on these individually or print it off for someone. Because the USPSTF website prints a really long list of things. There is this one page summary from American Family Physician magazine or journal, excuse me, and it's a little easier to read. And also you can see across the top of it that it divides out prevention recommendations from the USPSTF by age. It's actually really nice. You can just Google it and pull that up. And then it gives you, underneath this table, it gives you some of the risk factors that might be associated with some of the recommendations, where you can then decide, does somebody meet this recommendation or not, and is pretty easy to use. So that's another nice one to have at hand. E-Prognosis is a tool that I'm going to show you a little more of later in the talk as well. And it's a very, very interesting website, if you haven't seen it before, that allows you to do a cancer screening specifically for breast and colorectal cancer. As you see here, if you clicked on the middle button, it would take you to this screen. And then you put in patient characteristics, and it makes recommendations for you that includes prognosis as a factor in whether you would make a recommendation to somebody undergo colon cancer or breast cancer screening. I love this table from the American Geriatric Society. Unfortunately, it's in the Geriatrics review syllabus, so you have to buy the review syllabus to access it, but I've included one screenshot here. And then at the very end of this talk, in the kind of the bonus materials section, I've included the other screenshots for you to see. What I love about this table is that it also separates it into remaining life expectancy. If someone has 10 or more years of remaining life expectancy, you can use that first column. If they have 5 to 10 years of remaining life expectancy, you use the next column to the right. If they have moderate dementia, you use that column. Or if they're near end of life, then you can see whether something is recommended. There's also a strength of evidence rating on this table. And then something that this table considers that actually the USPSTF does not consider is cost effectiveness. And so you can see in this table whether something is cost effective or not as well. So again, the rest of this table is at the very end of the talk or in your handouts. And then lastly, this is the last one I'm going to show you. This is the healthandaging.org website. That is a really nice patient-facing website that's very user-friendly. And it was created by the American Geriatric Society Health and Aging Foundation. So it's all reviewed by geriatrics healthcare professionals and members of AGS. And you can see on this one that even this patient-facing website takes into account life expectancy due to other illnesses, where it says you may be less likely to benefit from cancer screening if you have a shorter life expectancy. So even here, they are letting the public know that life expectancy does play a role in recommendations for prevention. So just add an older adult into the mix of prevention recommendations to make things interesting and complex. Okay, going back to this money slide on what makes prevention and screening different in older adults. The first one is considering life expectancy, and I want to show you what that looks like. So how do you estimate life expectancy in an older adult, especially if you're seeing this on patient-facing websites and that sort of thing? There are two main ways you can do this. One is to use the National Vital Statistic Report tables, the life table data, and I'm going to show you that. And then another one is to use the E-Prognosis mortality indices, which is also pretty easy to walk through and gives you a general idea of what life expectancy is. I'll also show you that one. So this is the most recent report from 2017 that was published after that. And this is what the table then looks like. So you can scroll down to their age and years. So if you have someone who's 75, and then look at whether they're male or female, and also take into account what their racial or ethnic background is. I like this table. It's another way to look at that data that incorporates a little bit more information. And this table is actually published in a number of different articles. I put the resource down in this slide, as well as at the end of the talk, where one of the articles where you can access this table. But this shows you quartiles. So the top 25th percentile of adults aged 70, for instance, of men, live to be about 20 more years after age 70. That's about the top quartile. Then there are the middle 50%, that's about 14.3 years. And then the lowest 25th percentile is at the lower end, they're 8.4 years. So you can get a general sense of, if you're working with somebody who has more chronic medical conditions and you think maybe they have a lower life expectancy, you can get a general sense of what that might look like by age. And this is a table for women. And then showing you what the E-Prognosis calculators look like to estimate life expectancy. When you go to the E-Prognosis website, then you would click on the calculators button. It would take you to this screen, and then you can consider, where is your patient? Are they in the clinic or living at home? Are they in the hospital, a nursing home, or hospice? And once you click on that button, it takes you to the appropriate calculator, basically, that then you'll put in a number of characteristics of your patient, including a lot of functional information about them. And that then gives you a general idea of what their life expectancy is. We're going to go through that as an example at the end of the talk as well. So the next thing I want to talk about is not offering an intervention that someone won't benefit from in the time that they have remaining, now that we've looked at how can you get a sense of what someone's life expectancy is. That concept is called time to benefit, or it's also called lag time to benefit. And it's gotten a lot more press in the last 5 or so years. Unfortunately, these videos are just, pictures of the video. These are all also from E-Prognosis. They are excellent if you want to go and watch them. They're not too long, but basically these are two of the scientists actually who have put a number of the papers out on this topic. And they're highlighting conversations that they're having with patients about whether or not they would benefit from certain screening tests. So it's an excellent example and modeling of that kind of language. Time to benefit is the time between the preventive intervention, or when complications and harms are most likely. So for example, I keep using colonoscopies, but if you're doing a colonoscopy, the risk is right then when the colonoscopy is happening. Anesthesia, perforation, infection. So the time between when the risks are the most concentrated and the time when a person would see the benefits actually take place. That's time to benefit. This is one of the articles that was key in developing this idea. The main author of this article is Dr. Lee, who is the gentleman in the picture in the last slide. It's a really good read. And within that article, you'll find this table, which is a time to benefit table. It gives you a general idea of how long you need to, for example, treat somebody with a bisphosphonate for osteoporosis, about 1 to 2 years, for them to reap the benefits of that medication. Also, just pointing out primary prevention for hypertension. This is primary prevention for someone who has not had a cardiac history or a stroke history, or primary prevention with statins. Again, not for people who have had heart attacks or strokes. That would be secondary prevention. How long it takes for tight control of blood pressure, cholesterol to benefit a patient. At the bottom of this screen is intensive glycemic control for diabetes. And that you can see is 10 years time to benefit. That's one of the reasons why for older adults, we tend to relax our A1C requirements, for instance, and allow more looser restrictions, I guess, for people who might have more to lose from low blood sugars or tight control than they do from higher blood sugars, which take a toll on the body over time. This is the last part of that table, the time to benefit table, which has colorectal cancer, breast cancer, and prostate cancer screening. And you can see for those that the time to benefit is about 10 years. So if you don't have to remember all of these things, but if you remember that for cancer screening, the general rule of thumb is if someone has a life expectancy of less than 10 years, then cancer screening might not help them live longer, and it might be more likely to hurt them than to help them. So for older adults, it's really important to consider life expectancy and time to benefit when you're making recommendations for screening tests. Now I want to turn it over to Dr. Burdick so you can stop hearing me talk and let's hear what she has to say about what matters most and shared decision making for older adults.
Thank you, Dr. Wilkerson. I really appreciated listening to that and learned so much. So look forward to being the halftime intermission, and then we'll go back to do some cases with Dr. Wilkerson. So what we're going to frame in this section of the talk is really about shared decision making and how to broach these conversations with patients and why it matters. And Amy, next slide, please.
Sorry, it seems like I might have to have my video on to.
Oh, that's okay.
Doesn't make sense though.
Yeah, you shouldn't have to have your video on.
Okay. Well, we'll try it again. I'm going to stop my video and but just let me know when you want me to advance the slides.
Thank you, appreciate it. So really shared decision making is the holy grail of medicine when we take evidence-based medicine, patient-centered communication skills, put those both together in shared decision making with the patient to get optimal patient care. Next slide. This is fun. I'm happy to have you have your video on with me. Stay with me.
Let's see. Okay, it's going to stay right here.
So asking about why, asking about what matters most. Why is this so important? Why are we talking about shared decision making during this talk on prevention? I think 3 points that are really important would be, one is patients are really not asked about their opinions or well-informed about risks, benefits, or alternatives in preference-sensitive decisions. We are not asking nearly as much as we should. And when patients are asked, how informed are you? They report that they're not well informed. We also, as physicians, this has been shown in studies, we're not very good at being a substitute or a proxy for our patients and representing or guessing or diagnosing their preferences. And then the last, and this one I think is really key. If we don't ask opinions and if we substitute an erroneous preference that we have assumed a patient might have, patients will often go along with that recommendation, even if they don't feel well informed and if it's not consistent with their values. So it's really important that we have shared decision making when it's appropriate. And we like to think about this as, we always talk about wrong site surgery. This would be a wrong patient surgery if you're not going through and actually having a well-informed patient who is making a shared decision. Next slide, please. Excellent. When to use shared decision making. And I think this is key. If someone has a ruptured abdominal aortic aneurysm, it's not appropriate to do shared decision making. But if there are interventions, A or B, that have similar benefits and risks, or if A and B have different benefits and similar risks or different risks, or if there's something that's uncertain, and Dr. Wilkerson will talk about PSA testing shortly. These are perfect situations for shared decision making. When there are two right answers, having a patient share their preferences and what matters most is key. And then here are some data that I alluded to earlier. This is from a University of Michigan decisions study. And this is where patients were called from all over the country and asked about if they'd had a visit with a physician in the last year, and if they did, if there was a decision that had to be made. And all of those members then had questions about screening, about medications, about testing, and a few other things. When we pull out screening, when patients were asked, how often did your provider, did your clinician discuss the pros of the screening? Many remember it. So a third to almost half. When asking how often did doctors or clinicians discuss the cons, the negatives, the risks? Very few. So we're not really, as a system, always presenting a balanced pro and cons. And when asked, what was your general sense about what your clinician was recommending? 95% of them said, just do it. You know, the clinician is recommending that I just do it. And then when patients were asked, were you part of the decision when to decide about the screening test? Only 1 in 5 said that they felt like they were an active participant in the decision about screening. Next slide. So then, true or false, the statement that we hear often, patients don't want to be involved. And it's a little of both. So patients identify that they don't want to be involved necessarily in the problem solving, the technical aspects. They don't want to be diagnosing themselves or deciding their own treatment and testing options, or taking on the responsibility of being able to describe the risks and benefits. That is technical skill that comes with a clinical training. But what they do want to be part of is the decision-making process, because that requires knowledge that really only a patient can share with us. That would be preferences about types of testing options or choosing between treatment options. So patients do want to be involved, and there's a section where they do want to be involved, but they're still going to count on us to come prepared to discuss diagnosis, testing, treatment options, risks, and benefits. Next slide. Excellent. So then how do we share decisions? If patients are wanting us to describe risks and benefits and testing and treatment, how do we go about doing that in a way that's really truly effective so that we in our practice can feel more confident that our patients are part of the decision when appropriate? So this is a Cochrane review of randomized controlled trials that are evaluating patient decision aids. And we'll show several of these in the cases, but really key to show that randomized controlled trials really do show that patient decision aids increase knowledge, also yield a higher proportion of patients who can accurately describe the risks involved, as well as patients that are choosing an option that matches with their values. And interestingly, when talking about surgery specifically, patients often choose more conservative choices when they're more informed. And next slide. Excellent. So one thing that I wanted to go through today is to just focus on one section of shared decision-making that's particularly salient to screening. So you'll see there are 6 steps to shared decision-making. We're just going to hone into this section, provide, benefits, and risks, because this is a skill and there are some best practices. The first would be to use numbers rather than words whenever possible. When we say, it's a small risk and a small benefit, patients tend to overestimate benefits and underestimate the risks, and also just have generally less realistic expectations. Next slide. And we could all do an exercise where we write down what we think or what we hear when someone says rare, unlikely, probably, very likely. And it's really all over the board. And next slide. Excellent. So if we're going to use numbers, what are the right numbers to use? The first point, natural frequencies, I think is the most impactful to really to use in our shared decision making and our presentation of benefits and risks. And what that means is instead of saying 5%, we say 1 in 20, because it's something that really can be visualized and thought of and understood much more easily than using percentages. It's also important to talk about absolute risk rather than relative risk. Relative risks can be deceiving when we're talking about you're 2 times more likely to have something happen. But if that's really going from like 0.25% to 0.5%, it's probably not the best way to frame it. So talking about absolute risk, really, this would increase your risk by 0.25% is something that makes more sense intuitively to patients. And then balanced framing. So if you say there's a 1 in 10 chance that something bad could happen, there's a 9 in 10 chance something bad won't happen. And to really put things side by side and share both the risks and the benefits and the risk of something happening along with the risk of something not happening. And then graphics and pictures are so important, and perfect timing, Dr. Wilkerson, to go to this slide. So this is a sort of demonstration of doing all of that correctly. So this is the risk of complications 30 days after bypass surgery versus banding surgery. It has a pictogram. So this is 100 people. It describes the number of patients that will have complications, the number that will not, and really puts the 2 options side by side. And we do this all of the time in clinic for bisphosphonates. It is very, very, very easy for a patient to decide whether to start a bisphosphonate or not. If you can put these 2 pictographs and say, here's without and here's with, patients really find that to be an easy decision. But if it's more nebulous and it's just, this could happen, but there's a very, very small chance that this could happen, it can be a very prolonged and uncomfortable decision for patients, and they don't feel as well informed. So, pictographs, balanced framing, natural frequencies. And this would be another example of a pictograph showing the experience of 1,000 men who were offered PSA screening. Okay, Dr. Wilson, I think I'm turning it back, Wilkerson, turning it back over to you.
Great, thank you so much. And that was such a nice professional interlude. I apologize for the slides. They kind of had a mind of their own.
I was grateful that you were driving. Thank you.
Switching on their own. So sorry about that, everyone. I love this pictograph actually, because it really allows you to see what the risks and the benefits of prostate cancer screening are. This is for men 55 to 69. It's important to keep in mind, these are not the high risk men that we're talking about who we would consider screening at an earlier age. This is an average risk man, should they undergo prostate cancer screening or not. Of the 1,000 men who are offered screening, 240 get a positive result. Many of them will learn that they had a false positive result after getting a biopsy, with the potential side effects of biopsy being pain, bleeding, and infection. And of those, 100 get a positive biopsy showing definite cancer, so 1 out of 10 or 100 out of 1,000. Of those, 80 decide to undergo surgery or radiation treatment. It might have been that treatment happened immediately or after a period of surveillance. And there are high rates of erectile dysfunction and urinary incontinence in men who undergo surgery or radiation treatment, which you can see. Then 3 avoid cancer spreading to other organs of those men. 1 avoids death from prostate cancer, and 5 die from prostate cancer even after surgery or treatment. This just gives you a general sense of why screening for prostate cancer is somewhat controversial. So the last one on what makes prevention and screening different in older adults is considering their cognitive status. I'm not going to go into that right now, but there is an excellent recording on the YouTube channel that was just done in January by Dr. Amy Thomas from the VA on the rational approach to preventive care for persons with dementia, that if you miss that, you can go back and see it. And it walks through a lot of the similar things that we're talking about today, but applies it more to a population of patients who have dementia. So now we're going to try to put it all together for you with some of the showing you how to practically apply some of these things that we've been talking about. So this is a case that I created. 78-year-old African-American woman. Her health is pretty good. She has no functional or cognitive limitations. She quit smoking 10 years ago after a 30-pack year history. She has mild COPD, but doesn't need any controlling medications for her COPD, and she's not had any hospitalizations. Should she have a mammogram, a colonoscopy, and lung cancer screening? And I'm purposefully choosing the ones that make this case a little bit gray, as you will see. So let's first estimate her life expectancy. At 78, she's kind of in between the 75 to 80-year-old range. She's an African-American woman. And so just looking at the vital statistics tables, we see that her life expectancy is somewhere between 9.8 and 12.8 years by this table alone. But let's look at a few other resources. This is the other form of the life expectancy tables that if she is in the median of people her age, give her life expectancy at about 12.8 years, but can range from 7.6 up to 17.8. And if we take her information and plug it into the E-Prognosis calculator, then we put in a number of things about her function, her health, and we get actually two different tables. This is just one of them that I'm going to show you that show her risk of 5-year mortality, 10-year mortality, and 14-year mortality. And if her risk of, let's say, 10-year mortality, because we're looking at cancer screenings and we're thinking about 10 years is what we're looking at. If her risk of 10-year mortality were about 50%, that's where we would say her life expectancy is about 10 years. So this is putting her life expectancy beyond the 10-year mark, closer to the 14-year mark, given her clinical scenario. Next, you want to have that time to benefit table handy, or just a general sense of what we were talking about as far as about 10 years for time to benefit for cancer screening. And for the E-Prognosis, if we put her into the area of the E-Prognosis cancer screening specifically, so there was the calculator and the cancer screening. If we clicked on the cancer screening one that was in the middle and then chose breast and colorectal cancer screening, that would take into account that mortality index that gets calculated and then give us an idea of whether this particular patient with her set of characteristics is likely to benefit from colon and breast cancer screening. And for her, it ends up not being that clear whether she would benefit. And it says that her thoughts and feelings should be the main driver of the decision to screen or not. If you're on that screen and you scroll down farther, you'll see some of these pictograph tables that, or some pictographs that then show you what the risks and the benefits are. So the 1,000 people like her who got tested for breast cancer, and this one's for breast cancer only, 100 people will experience harm in the first year. 1 person would avoid death from breast cancer, and then 300 would die whether or not they were tested for breast cancer. It also just lists out in words the benefits and the harms of screening mammograms. And on the same website, the E-Prognosis website, there are additional decision aids beyond what I just showed you that you can hand out to patients for colon cancer screening and mammogram screening for women who are of these age groups. this is what one of those decision aids looks like. It's really nice to follow. And this isn't the beginning of it, but if you were to pull it up, you'd see that it's about 5 or 6 pages long, but pretty nice and easy to read. So women of her age who continue to have mammograms, there would be 100 false alarms. Of course, if they did not have a mammogram, then they're not at risk for a false alarm. Then it talks about what additional tests might look like if there was a positive result. They might need additional mammograms. They may need to undergo breast ultrasounds or biopsies. And of the 1,000 women who had a screening mammogram, 3 women would die of breast cancer, as opposed to 1,000 women who did not have screening mammograms of that age range, where 4 women would die of breast cancer. So you can see that the net positive result would be 1 less woman out of 1,000 may die from breast cancer in those who choose to have mammograms. If you plug it into the Uspstf calculator, then you would get a report that looks like this. And you can see across the top that there are there's general information. You can click on the button that describes the rationale behind the recommendation. You can click on the clinical button, and then there are other resources that they show you. One thing that I wanted to highlight from this tool specifically is that there's a lot of information there. And for example, it also pulls and takes into account that whether there are racial or ethnic differences in outcomes and mortality rates. And so if you're looking for that type of information, the Uspstf calculator would be a really good place to go. It's not as kind of patient forward in terms of being able to hand off to a patient and say, go through this calculator and kind of see what your feelings are after, or go through this worksheet or this handout and let me know what you think after you review this information. But there is really a wealth of very helpful information here that gets updated on a regular basis. So you can also have the confidence that you're getting the most up-to-date information on this. And then for lung cancer screening, this is what you would see from the Uspstf. It also gives you the grade of the recommendation. So for her, lung cancer screening would be a grade B recommendation, as opposed to colon cancer screening, which was a C recommendation, which is a maybe. This is just to highlight that the Uspstf is very committed to addressing systemic racism through their clinical preventive service recommendations. This is a newer article that was published in JAMA just from this past January. So going back to Mrs. O, should she have a mammogram? Maybe. Should she have a colonoscopy? Maybe. She's kind of right on the line where it might help her live longer, or it might be more likely to cause harm, physical, psychological harm, and where the decision ends up resting with her. Should she have lung cancer screening? Yes, probably, unless, of course, what matters most to her is avoiding tests, avoiding medicalization, and if she were somebody who would not want to undergo treatment or potential surgical resection, then having a mammogram, a colonoscopy, or lung cancer screening may not be the best things for her either, if she wouldn't want to take the next steps if she were to have a positive result, of course. So I wanted to just give you this example that's not super straightforward, because that is clinical reality, and that's often kind of where we are, what we are facing in real life. This is one of the last slides. We're almost done. And I just wanted to say a little bit about how to communicate that balance of benefits and harms, because what you say matters. We all know what you say matters. And if you say that you might not live long enough to benefit from this test, that does not go over as smoothly as saying this test is not going to help you live longer, or saying that this test is more likely to harm you than to help you. That has been studied by Dr. Schoenborn She was the woman in the video pictorial that was side by side on the time to benefit screen that I showed you, who really studies communication around this thing. Not only do you want to have good tools that you can utilize to give to people that help them to visualize what their risks are and allow for shared decision making, but then you want to think about what you're saying to them and the message that they're hearing from that. The arrow on the bottom of the screen is from E-Prognosis, and it is at the very bottom of the shared decision-making tool that, that you can pull up and give to people if you want. That after they go through it, they get a score and they can kind of see where they are along that arrow in terms of whether undergoing a mammogram might be helpful for them or not. And this is one of the last slides. Just a reminder that there are grade D recommendations from the USPSTF, and those are things that we recommend against. Those are not things that we say may be helpful or maybe not, but when they've looked at these things with research and with their clinical acumen, this is a recommendation against undergoing these screening tests for asymptomatic older adults. So in summary, prevention is clearly an important part of older adult health and really is an art. Have to balance the benefits and the harms of screening. You should consider life expectancy, even if it's just a general gestalt, when making recommendations for or against a preventive screening test. You have to think about how much time to benefit a preventive measure entails, thinking about the 10-year mark for cancer screening. And then I hope that this showed you some really helpful, patient-friendly tools that can help with communication around these concepts. And then, of course, don't forget that shared decision-making and what matters most to older adults is really key. That's the end.
This is great. And we actually already have a couple of questions. So Mary is wondering on the AGS cancer screening page, which was back at slide, I think 27, does the cost effectiveness column represent values from the standpoint of the patient, insurance carrier, or providers involved?
That is an excellent question. Let me go to, so these are your bonus slides that you can download. I'm just going to go to one of the last ones here, and which is the footnotes. And I wonder if I can move my video around. Oh, there we go. So cost effectiveness, it says, is the ratio of costs of a test or procedure compared with the benefits of the test or procedure. It's expressed, and this is common in public health, it's expressed as cost per year of life saved. That is the most common way in research to decide whether something is cost effective or not. Cost per year of life saved, or quality adjusted life year saved. So it is from the perspective of the patient. I'm not sure if that answers your question. That's all of the information I really have about how they went about considering that. I hope that helps.
Well, I think Mary will let us know. Let me go on to the next question while she ponders that. Cynthia is wondering, how often do you actually talk with patients about their life expectancy in terms of likely actual years remaining? Or is it more common for physicians that say something general like, at your age, it might not actually benefit you?
Yeah, and that is a wonderful question. How does this actually play out in real life? As you all kind of heard in the introduction, the majority of work that I do now is actually more along the post-acute care, long-term care, outpatient palliative care, or home-based palliative care, and hospice world. So personally, when I'm talking with patients about life expectancy, I'm often thinking about whether they are hospice eligible, meaning whether I think that their life expectancy is about 6 months, or whether they are not hospice eligible. So I don't actually often have the opportunity to talk about screening tests in this way, it's important always to invite yourself to have that conversation with people. It may not be that you launch into what you think their actual life expectancy is. Rather, you wrap that up in your own mind when you're talking with them, and then present what you recommend. Like, this is a decision that you have to weigh the risks and the benefits, such as with Mrs. O, or whether you would say this test may do more harm than, have a higher risk of harming you than helping you, and probably wrap it into the message that you're giving them rather than actually telling them what their life expectancy is, unless of course they're asking for that. It's a great question.
Mary missed the follow-up question because she was answering an urgent text.
Oh, no.
So I'm going to refer her on to that slide where the definition is.
Sure.
I'm wondering if you might be willing to respond a bit more about how you address some of the rumors or things people read in all kinds of resources about prevention strategies that don't really have an evidence base, but people are very anxious to believe them and address them in some way.
Yeah, I think that's a great question. And the one that comes to mind is when you are at a health fair and they offer carotid screening, for instance, or that's one of the ones that most comes to mind. If patients are, I think the first thing to keep in mind is that it's really kind of part of our ethos to say, if I can prevent something, then it's going to help me, or which, again, it doesn't necessarily weigh the potential harms of that test, or where that might take you kind of psychologically. If you have some blockage, for example, in your carotid that is not clinically relevant because you've never had any symptoms of a TIA or stroke-like symptoms. So I think it's a really excellent question. I'm going to go back to in this screen just a little bit. Actually, let me see if I can find it. Apologize for just a second. Okay, so looking at carotid artery stenosis, for example. So one thing that I like to, because I do get these questions from folks, is to say, we actually recommend against that there is not strong evidence that test is going to help you live any longer. Going back to the language around it, if they're asking you for tests, should I screen for ovarian cancer? Oftentimes I try to address it as I wish there were a good screening test for ovarian cancer, but unfortunately, the tools that we have do not help women live any longer. This is, of course, women who are not very high risk with certain clinical syndromes that incorporate multiple types of cancer, like ovarian cancer. This is for asymptomatic women. So I like to say, I wish that things were different, but we don't have a good screening test for that has been shown to really benefit women and give them a longer life or a healthier life. Does that answer the question, hopefully?
Yeah, that's really helpful. Thanks.
Mm-hmm.
Do we have other questions? I really appreciate you including this handout at the end, which is nicely informative, but I can understand not something you want to slog through in your presentation.
Exactly. So hopefully the way that this presentation has been laid out has been interesting for you and informative in some ways without going through, each individual recommendation. Sometimes that can be very helpful and can help you if you're really thinking about, specific individuals. Where should I offer them? I got a question the other day about a 100-year-old woman who had a DEXA scan done and came back, showing osteopenia. Should she get osteoporosis treatment? So I was talking with the family medicine resident about, time to benefit, what her life expectancy is, that sort of thing. So going through each of these individually can be really helpful, especially if you have specific patients in mind. But since they can change and there's so many of them, we thought that it would just be more helpful to, to present to you where you can go for them, how to think about it, how to interpret it, and just give you a little bit of this richness that is the kind of preventive world. So I hope that you all agree and have found this helpful.
Do you have an opinion about the U.S. Preventive Services Task Force position on cognitive screening, which is that the benefits aren't clear?
Yeah, so that's one that actually there's a discrepancy about. I think, one thing to keep in mind is that having the USPSTF has an I statement recommendation for cognitive screening. I statements mean, and I include this in your bonus slides, that the current evidence is insufficient to assess the benefits and harms of this service. This is for asymptomatic individuals. So if someone comes to you and is having, has some symptoms or has examples of where they may, be concerned about their cognition, then it is absolutely appropriate to screen them for cognition with one of the typical tools that we use, which include the MoCA test or the MMSE or the SLUMS test. Or if there's even more evidence there, then thinking about sending them to speech therapy to do more even in-depth cognitive screening. So I can see where they come from the standpoint of weighing the benefits and the harms. And practically speaking, I find that a lot of patients have concerns about their cognition, and so they tend to be more symptomatic, and then I tend to want to screen them and kind of see where they are, if for nothing else than for a starting point where we can look back and say, in 2018, we did an MMSE, it was normal, and now here we are in 2021, and they scored a 26 out of 30. So that's how I don't necessarily put a lot of weight on that, but do tend to see a lot of people who have concerns about their cognition. And not someone who's just walking into the office feeling great, no concerns about memory, and saying, well, let's screen you with a MoCA.
So another question out of curiosity that I have, if you don't mind, is have you experienced a fair number of older adults who have held off on their screening because of COVID? And what are your recommendations right at the moment for routine screenings?
I have, it's been such a crazy year and a half.
Yeah.
And the majority of folks that I've taken care of, they may be living in institutions, and so we've still been able to do some of their screening tests, but their life expectancy is generally less than 10 years. So it's been more kind of anecdotal that I have read and sort of tried to keep up a little bit with the literature about what people are doing with screening. So anecdotally, I would say I haven't experienced a big decline in screening tests with my own patients. But as far as the outpatient world, I do think that we're going to see people who have put off screening and end up presenting with disease that's in later stages. So I would recommend clearly that people get vaccinated against COVID and then think about picking back up their screening recommendations where they are. And it may be that they decide, like for colon cancer screening, to do the FIT test instead of going for the colonoscopy, or to opt for the, some of the less invasive screening tests if at all possible. We'll see what happens. I don't have a good answer for that question, but it's an excellent question that I'm also very curious about.
Cynthia mentions that she also, as a social worker, thinks about patients' finances, location, and access to actual health care is integral to their decision about screening. if they can't afford care following screening or live in a really rural area far from care? Do various tools take this into account? I know physicians would probably be aware of this, although they may not know their patient's financial status.
Yeah, that's a great question too. And of course you take that into account because you care about your patients, you are walking alongside them in their journey, and you understand how, or you try at least to understand how they might make decisions. And that, you know, has something to do with their values, of course, as well. And I would say that, sorry, I just got distracted. I'm not done yet. I'm not done with my talk yet. Oh, okay, sorry about that. Sorry about that distraction. I would say that that, you know, that those individuals in rural areas, what I wanted to say, I'm back on track with my train of thought. The USPSTF actually does not take cost into consideration when they make their recommendations. Interestingly, that table from the AGS that I showed you does take cost effectiveness into consideration. The USPSTF recommendations are often utilized though by insurance companies, even though they're not intended to be. They're often utilized by insurance companies to decide what, or even by the government to say, to mandate what should be or has to be covered by an insurance company or not. So you may see that the USPSTF recommendations then get reflected in insurance coverage. That of course does not take into account, you know, so most older adults will clearly have Medicare. So you'll see that reflected in what's covered, but then you're right that there's still copays and there's still, there's a lot more to cost than just whether something is covered or not, especially if you find something and then have to undergo those other tests. So yeah, it's a really good point.
Well, I don't see any other questions. So I want to apologize to Drs. Wilkerson and Burdick because I was worried about the timing of this, given there were all these slides. And then I realized it's this extra wonderful resource material. So thank you so much for that. And we will see everyone next week. Kind of along a similar theme of prevention, next week's talk will be on vaccinations, and not just COVID, but I'm sure that will enter into things a fair amount. Drs. Wilkerson and Burdick, thank you so much, and everyone have a wonderful week.
Thank you. Thank you so much. It's been really fun to be here. So thanks for inviting us.
Thank you.
Bye-bye.
Bye.